very good morning, sir. They say 1/5 of the world population of tuberculosis lives in India. So why is it that India is the epicenter of tuberculosis in the world?
Well, we are the most crowded country. If 1/5 of the population of the world lives in China, 1/6 of the population of the world lives in India. And we are much more crowded. Which even China has enough number of tuberculosis patients. But tuberculosis will keep on perpetuating on certain basic facts. Number one, a crowded living. Number two, a poor nutrition. Crowded living perpetuates spread of infection from one person to the other. Poor nutrition again perpetuates the continuity of active infection. Another reason in these populous countries is going to be a larger number of people now living beyond 60 years of age. A lot of demographic changes taking place in the whole world as a matter of fact, but certainly in China and India, a tremendous demographic change is taking place. A large number of people are going to live beyond the age of 60 years. There is a time when a common man's immune system starts deteriorating. The immune system deteriorates, number one, because of age per se, diabetes, two, and people are on, by circumstances, people are on medications because of, let us say, rheumatoid disorder, on immunosuppressive drugs, organ transplants. All these things bring down the immunity of the people, and then you invite the infection, invite the disease, active disease. This is it.
So, moving on, what is the natural history and behavior of pediatric tuberculosis as opposed to the adult tuberculosis?
Almost all children in, I would say, I think we'll talk of Indian subcontinent. They pass through a phase of being infected by Mycobacterium tuberculosis but not showing the disease. There's a called primary exposure. Most of these children will have the primary exposure but not the disease. They heal and develop what we call adaptive immunity or cell-mediated immunity. Again, I think very wisely government has put in that every child should undergo BCG vaccination, which again increases or improves the cell-mediated immunity, and chances of getting florid infection becomes less. Probably had all this not been done, our country would have probably have much more virulent tuberculosis than what we are seeing today. In children, tuberculosis, if diagnosed well in time, treated well, I think they heal very well and the disease can remain healed for the whole life. In adults, I think the healing process is relatively slow. That's all what I would probably say.
So just as a continuation to this question, is eradication of tuberculosis from India an unreal dream?
But the dream is worth it.
Absolutely worth it.
You see, WHO wants eradication of tuberculosis from the world in 2035. Our Prime Minister and the government, they want it to be eradicated by 2020. Did I say it? 35. WHO was 35. Our government is 25. I prayed, they are not rhetorics. I pray and effort goes on. I think there's nothing wrong in the idea. Let people try, let people think about it, and minimize overcrowding, minimize undernutrition, diagnose them early, put them on effective anti-TB drugs. I think we can minimize. But don't forget, even the developed countries have TB. You see, the whole philosophy of TB revolves around an interaction between the haves of the society and have-nots of the society. All haves will have to have the help of have-nots. And that is how the disease from have-nots can pass on to the haves.
What would be the most atypical or surprising presentation of tuberculosis that you have seen in your clinical practice?
The patient comes to you for treatment of ankylosing spondylitis, rheumatoid disorder, comes to you for diabetes. And then you investigate, you find there is a concomitant tuberculosis as well. I think the old teaching, try to diagnose one disease in one patient, should be modified. My generation was taught, diagnose one disease in one patient, not today. Why not today? No, because we are living for a much longer lifespan. We have many more investigative facilities available to us, and if you can afford to do complete investigations, many people will be found to have more than one disease. In addition to what the patient came for, there would be a comorbidity.
So basically, the concept of comprehensive evaluation of the patient has come into.
Must be done.
So normally we have got patients in our OPDs who had already started on AKT empirically, and we are yet to have any kind of tissue or histopathological diagnosis before a biopsy is done. So what would be your advice? Should we stop the AKT before giving biopsy, or can we let it continue?
Again, I think in every case, your clinical judgment will remain supreme. Patient had standard investigations done according to facilities. Ideally, to my mind, every spine should have a MRI done at least once when we start the treatment. Ideally, if we can afford it. I may not say so for other joints, because MRI of non-spinal tuberculosis are non-specific. The findings in the MRI are absolutely non-specific. Rheumatoid disease of the knee, hemophilia of the knee, or hemarthrosis of the knee, post-traumatic effusion of the knee, villonodular pigment synovitis of the knee, and tuberculosis, they can probably mimic each other. They can, of course, show you, not in addition to thickening of the synovium, collection of fluid, erosion of the bones, all this can be seen, but very unlikely to give you the diagnosis. Whereas in the spine, there is quite appreciable specificity, whereas in the articular joints, I think sensitivity is there, but specificity is not there.
They call tuberculosis the great masquerader for not for
Sure, I keep on repeating ad nauseum that tuberculosis can mimic any disease and any pathology can mimic tuberculosis. Sometimes it is difficult to make that assessment. Should I stop anti-TB drug and then do the investigation? But I think if the patient already had anti-TB drugs, say for about 2 or 3 months, I don't think a biopsy is going to be very useful to us. But as it is, every time you put a biopsy, you don't get you don't get the best of yield. You don't. You still depend upon so many factors. I mean, it's so rare to get a gazeating granuloma. Granuloma you may get, but I would keep on repeating. Every time you obtain tissue with the aim of testing for tuberculosis, we must subject that tissue to at least 3 investigations. 1, histology. 2, microbiology. 3, serology. Even aspiration of the knee joint, if you are keen, the last step of the aspiration, just make holes with your needle, just scrape the under surface of the knee or hip or elbow. You might get some tissue which can give you a small histo. I think every time at least these 3 tests must be done.
So, in this era of evolution of multi-drug resistant tuberculosis, how much of a role does drug sensitivity testing play, and is it always a must?
No, I mean, if possible, if possible, do the drug sensitivity test. But also kindly remember, these are in vitro findings. They are not in vivo findings. One, in vitro, we are testing a single drug. In vivo, you are giving more than one drug. You are giving at least 2 drugs. Ideally, 3 drugs, I would say. The behavior of microbes when it is being attacked by multiple drugs would be different than the microbes attacked by one drug. So there's some degree of reliability, but I won't say we should consider them as absolute guides.
So some are against the rapid action multiplier, some act against the slow multiplier. So the entire gamut is being covered because of multiple drugs.
Yeah, and I think re-emphasizing what is the best time to put a antibiotic. It is the replicating mycobacteria that are killed. The non-replicating mycobacteria are not killed. They will be killed only if they come into replication. The non-replicating mycobacteria stay comfortably within cells and giant cells. Stay comfortably. Only when they start replicating that our antibiotics will work. Again, for the last few years, my brain is agitated. These are all bactericidal drugs: streptomycin, INH, rifampicin, pyrazinamide, allicin, or ofloxacins, whatever you call them. They are cidal drugs. But ethambutol is not cidal. Ethambutol is a static drug. For the last few years, I have been debating about it. I'm not in a position to do the testing, otherwise I would have done it. When we give ethambutol, we are only making the microbes static. Are we serving the true purpose?
Are we promoting resistance?
Are we permitting? Are we not suppressing the activity of the cidal drugs to kill these bacteria? That question mark is in my brain for the last few years, but I don't think I can do the testing now, but some young people like you should do the testing.
I think this begs a role for future studies to evaluate again.
Sure.
Maybe we need to look at our
It should be evaluated. Now, see, we keep on discussing everyday drug, alternate day drug, twice a week drug. Again, the formula is the same. The drugs will be infecting only but the best attack on the microbes are when they are replicating. That's it.
Moving on. So when a patient comes to us on conservative management and we are assessing him on follow-up, traditionally we've been taught clinical, radiological and biochemical evaluation. So what would be your advice to assess the patients for follow-up when they are coming to us for a follow-up?
I think you are absolutely correct. All the three. Clinical assessment. In clinical, the patient also will tell you something. No? Let us listen to the patient. We listen to the patient. We look at the patient. We do lab investigations. We do periodic X-ray examinations. I think all this is good enough. But in the early stage, if a patient can afford, circumstances can afford, an MRI would be a useful investigation. You can't afford repeating MRI again and again. But I think before you start thinking of stopping anti-TB drugs, one MRI at that time may be of some value.
To compare it with the pre-treatment MRIs.
And for future as well. It will be, I do tell all my patients, you are healed, switch on to normal activities, but come and say we have after 2 years. This is what I tell them. And they do come.
So we should always plan for an extended follow-up
Sure.
even after the completion
Sure.
of treatment. So sometimes we encounter patients who have, after having taken the intensive phase of prescribed duration, they still show no response or no clinical improvement. So can we extend the intensive phase, or when should we suspect we are going towards an MDR or an XDR probably?
That's a very difficult situation. We have given a extensive phase.
Yes, sir.
Extensive phase. The very first one is the extensive phase, generally for 4 to 5 months, minimum 3 drugs. And at the end of it, you still feel you're not comfortable with the response. I think in such a situation, one will have to probably again give an extended phase, but with modification of the drugs.
So do we have to repeat a biopsy? Then should we go suspect XDR or MDR in that case? In this,
If it is tuberculosis, biopsy is not going to give you much information. But if it is what we are thinking is tuberculosis, maybe something else. In that case, one can think, okay, let me try obtain a tissue. But if you talk to these patients in detail, you will find some lacuna somewhere. Was the patient taking inadequate medicines? Were these medicines substandard? Was he not given good nutrition? I think we must keep on emphasizing, in addition to specific ATT drugs, we must also take care of the supporting therapy. Heliotherapy has a role, vitamin D has a role, nutrition has a role, high protein diet has a role. Think of it, before anti-TB drugs were available, how were we treating them? See, I belong to that phase that have seen it. Diagnose the patient, put the patient in plaster, ask them to go to a sanatorium where you will be exposed to fresh air, sun rays, good nutrition. And 50% of them healed, 20% never healed, and 20% died. But 60% did have some degree of healing. Nutrition, rest, heliotherapy, so-called sun rays exposure, or I would say vitamin D, and nutrition. They have a role to play. And if you start thinking that it is probably an MDR, we have tried what we call immunopotentiation. There has been a discussion all over the world finding an immunopotentiation. We are not very sure what is the best available, but we have been trying an immunopotentiation technique. It's been mentioned in some articles. We have succeeded in about 80% of people. Whenever we suspected MDR, medicines have been tried at least for 4 or 5 months, not responding. Okay, let me put the patient on immunopotentiation. It probably works. I'm not saying this is the best. I'm sure the best one can be found out. But today, whatever is available, we do it and it helps. In 80% patients, it helps.
So basically, we should try and keep a broad overlook over the patient and try and improve the general health.
Sure.
So moving on, what would be the indication to stop AKT, as in the treatment is complete? When would you be satisfied to?
Minimum 18 months. Slow responders, doubtful responders, 24 months. But I don't think it should be less than 18 months. Nowhere in the world. In fact, if you look at the literature around the world, even though with a lot of thinking, a lot of passage of time, they are coming around to the figure 18 months, almost all over the world.
So what would be distillation of your experience while we are going on to administering second line drugs? What would be the things that we should watch out for? What is extra precautions we should take?
So again, the same thing. If the patient is not responding favorably in your extensive treatment of 5 months, then you start debating, am I dealing with a clinically refractory case Technically you cannot call it MDR unless you have harvested the microbe. How often we can harvest the microbe? So one can say clinically refractory case. That is the time when you start thinking, can I add another first line drug, or should I add a second line drug? And after all, we have enough drugs available. I don't think we should certainly think beyond INH, fempicillin, parazenamide, levoflox, oflox, ethambutol. Still, no doubts. Then linozid. I think these are fairly safe medicines. For refractory cases, in addition, well, of course, streptomycin injection, or other injectable glycosamide, or what do they call them, they are also useful. In that, the practicability comes into difficulty. However, streptomycin can be given easily for 90 injections. An adult can easily tolerate 90 grams of streptomycin spread over a period of 3 months. One of the medicine I was using very frequently was anti-leprosy drug.
Levamisole?
No.
Clofazimine?
Yes, that's right. Clofazimine. See, clofazimine is a anti-leprosy drug. कई और क्या नाम हैंडसॉन वगैरह ऐसे भी नाम रखे हुए हैं. Okay. I think it's a beautiful drug. Patient tolerated very well. It's very effective. One can easily give it for 5 months. But it only changes the color of the patient to black, which will get reversed in about 3 months' time. Every patient should be told in the beginning, I'm putting you on clofazimine. You're going to use clofazimine roughly 150 milligram per day for 3 or 4 months. Your color will become dark, but it will come back again once we stop the medicine. Last week I learned that the pharmaceuticals have stopped making clofazimines. It was only last week I learned. But this is unfair. Why have they stopped? Because probably government doesn't permit profit on it. They are not sitting the manufacturer is not a charitable place. He is making it for the sake of earning. This is what happened last week. I know it's difficult to tell you all these stories.
Yes, sir.
Total hip replacement done in a patient who had TB of the spine. The hip joint got infected. It had to be removed. Put in a spacer. Came to me. I say, you have to wait. After the spacer, the patient has been again replaced. But all this is 3-year story. And then question came to me, what anti-TB drugs? I say first line plus streptomycin for 3 months, first line plus clofazimine for 3 months. And the reply comes to me, sir, clofazimine is not available in the market. This is the status last week. May change. I don't know.
Moving on, sir. Is an all posterior approach for tuberculosis sufficient? They say tuberculosis is an anterior disease. So what would be your indications for the anterior approach in today's world in cord spine?
If we are operating for the sake of tackling the diseased area, you have to reach the diseased area either through anterolateral approach or through transthoracic, transpleural approach with least disturbance to healthy parts of the vertebral body. I would say posterior alone approach doesn't seem to be rational in the presence of a destroyed anterior elements. This is how I would put it. Now, if it is a healed disease and you still need something to do a decompression in a secondary canal stenosis, then it's a different game.
And all posterior probably suffice.
Yeah.
So what they say, operating a wet lesion in tuberculosis, you could be having two lines of management. Where initially you could give AKT for a few months, let it dry up, and then go intervene because you'll not be having a hold for the implants. Probably, what would be your indication for operating on a wet lesion in tuberculosis?
Wet lesions. The operative indications are the same. If a neurological complication, development of neurological complication while the patient is on treatment, neurological complication which is not responding, neurological complication which is deteriorating, you see, then if you are doubtful about the diagnosis, if you think the disease is not responding, it is not resolving, then we have to go to the anterior part with the active diseases there. However, all the same, respect those tissues which are healthy, do minimal possible damage to the healthy areas.
So, sir, what would be your protocol for serial follow-up MRIs as a guide for the continuation of AKT? So, like you previously mentioned that at the end of tuberculosis, would there be a role for an MRI in the process of the treatment of AKT?
If a patient can afford, I will take an MRI around 6 months.
That's a big question in India, the affordability of a patient.
Sure.
So, like we have already known over the years that radiological recovery would lag behind the clinical recovery of the patient. So, why does that actually happen? What is the phenomenon, pathophysiological phenomenon behind that?
See, radiological recovery, imaging recovery takes time. And what are we expecting in imaging recovery or radiological recovery? We are expecting that the osteoporotic bones should get remineralized. It will start remineralizing only when the disease has healed. It cannot start mineralizing so long as the disease is active. So once the disease comes under control, or during that process, when the disease is coming under control, a repair process starts from the periphery. And that repair process, what is it? Repair process is highly vascular granulation tissue. All the repair is going to take place by highly vascular granulation tissue, which would come from where? Not from the diseased area, but from the periphery area. But we all know it. AVN, the repair is taking place from the healthy area. Similarly, diseased segment of bone, the reparative granulation tissue is going to come from the healthy area, and that is the area which in MRI will show abnormality. It will show increased activity. That is how it looks a little worse than the first MRI. This is the reason why. Otherwise, it's a process of repair which just shows an extended area of hyperemic state.
So the clinical message for the treating physician should be, you should wait for clinical, you should assess the patient clinically and overall, not just panic at the first sight of increased disease on the MRI.
Area of abnormal signals would be much more on MRI around about 5 months, just because that peripheral healthy area is now producing reparative granulation tissue from vascular healthy part of the bone to invade or to repair the diseased area.
Moving on, sir, in this era of litigations and medical legal concerns, what is the ethical and medical legal concern regarding empirical AKT purely on clinical suspicion, or only the practice of starting AKT on a basis of suspicion of tuberculosis? Is tissue pathological diagnosis an absolute must despite strong indications of AKT, of tuberculosis?
In legal conditions, and my book works there. We do take that book
As a court, in the court of law.
Anyway, but I think on the very first day we should write down clinically, radiologically, the best clinical diagnosis is this. I think we should write the best clinical diagnosis. In case of doubt, We write on another sentence, in case of doubt, open biopsy, or whatever you like to use the word, maybe best is open biopsy, indicated the patient. But if there is any doubt, and then again we can write it down, open biopsy for tissue diagnosis, for histology, micro, zero. All the three should be. That's it. Do I have patients in whom all this has been done and still you go to the court? Yes. I've faced it myself.
So I think eventually your counseling and communication with the patient makes a huge difference in the number of litigations that you go.
You see, it's unfortunate. Some of us are responsible for it. One of the colleagues is treating tuberculosis of the ankle joint. Patient is not responding. The patient's attendance goes to the court. And the question comes, is an orthopedic surgeon qualified to treat tuberculosis of the bone, tuberculosis of the ankle? This is the question in the court. Why should it not be treated by a TB specialist?
Something to ponder.
So then again my book goes there.
It's accepted in the court of law. Done. Thanks.
Hello friends, it is an honor for us to have with us the blessings and company of the great Dr.S.M Tuli sir. Sir, we'd like to start asking you about our learnings from the MRC trial and the role of middle path regime in today's times in the year 2020, sir.
With the availability of effective anti-TB drugs, with the availability of sophisticated investigations, I think the middle path regime's importance has increased further. Middle path regime was propagated, or let us say designed, when no MRI was available. We didn't have, some of the effective drugs were not available at that time. Even at that time, we could think that a large number of patients of bone and joint tuberculosis can be healed by anti-TB drugs. Today, you have the opportunity to make a diagnosis at a very early stage. The earlier stage diagnosis almost ensures that anti-TB drugs will help you most. You can make the diagnosis today in a pre-destructive stage. If I can make a diagnosis of any tuberculosis infection in a pre-destructive stage, I am nearly almost certain that anti-TB drugs will work and the patient will be healed by a non-operative intervention. It also provides us an opportunity to make a diagnosis if a patient does not respond to the anti-TB drugs. These new investigations are able to guide us. Here is the patient who will require surgery. I think on the whole, if I look at on the whole spine, nearly, I would say, let's say broadly speaking, roughly 70%, 75% of patients, if diagnosed early, would heal by anti-TB drugs alone. Of the 20% or 25%, when we'll have to start thinking, does the patient need surgery? And the surgery would be essentially not for the treatment of primary disease of the spine, but for preventing, eliminating complications of spinal tuberculosis, or in case of doubtful of diagnosis of disease.
So we would conclude that tuberculosis is essentially a medical disease, sir?
Tuberculosis of the spine, tuberculosis of the bones and joints, they are basically medical diseases. Surgery is needed for 1, prevention of complication, 2, treatment of complication, 3, when you are not sure of the diagnosis. One can add a 4th word, operate to improve the function. if needed by the clinical circumstances.
Sir, what is your from your vast experience, what is your opinion about the incidence or prevalence of atypical mycobacteria and their clinical course and behavior in osteoarticular tuberculosis?
We do talk about atypical mycobacteria, but on the whole, one should also be aware of it. You label a typical mycobacteria, you label an atypical mycobacteria, you label them Mycobacterium tuberculosis avian, Mycobacterial tuberculosis marinum, Mycobacterial tuberculosis kansasi, Mycobacterial tuberculosis abscessus. You can label these only if you harvest the mycobacterium in a broad spectrum of disease. How often you can harvest the Mycobacterium tuberculosis? In our experience, we tried it in, I'm talking of government institutions, at general hospital clientele. We could not harvest Mycobacterium tuberculosis in more than 20% of the patients. And from amongst these 20%, I think a very small number was atypical. I would probably put it at just 1 out of these 20%.
Sir, despite the fact that Mycobacterium tuberculosis is classically described in microbiological textbooks not as a fastidious organism, unlike other fastidious organisms, yet why is it so difficult for us to isolate this organism?
Number one, in a bone and joint, number one is a paucibacillary disease per se. Pulmonary tuberculosis is a multibacillary disease. Osteoarticular tuberculosis is a paucibacillary disease. And by the time a patient reaches a hospital, I'm talking of a common patient in our great country, a common patient. 70% of people in our country live away from the metropolitan cities. A common person, by that time he reaches you for treatment, he has already been on antibiotics. He has already been on medications by the family physician. He may not have made a diagnosis, but he is putting the patient on treatment, say, for complaint of fever, for complaint of pain. Many of these patients who reach a hospital in a general setup have already had antibiotics, and many antibiotics which may not be specifically anti-TB antibiotics may still have a anti-TB effect, and that is what makes the harvesting of these mycobacteria difficult in a generalized clinical setting in our country.
Sir, despite various advances in medical sciences, be it at molecular or genetic level, why is it so that we are not able to formalize a definite medical regime for tubercular management? Previously it was alternate day regime, now it has been changed to daily regime, and we never know whether this is the last lap. Why is it so that the medical management of tuberculosis, and more so osteoarticular tuberculosis, remains such an enigma to us?
I think if we should listen to the experience of people who actually see the disease. See, you go to WHO sometimes. Most of the chairs are filled up by white men. I don't mean any offense to anybody, but most of the chairs are filled up by white men, maybe one black man, and maybe one brown man like myself. I have been there 3 or 4 times as a temporary advisor to WHO. Many discussions come from those people who have neither seen tuberculosis nor treated tuberculosis, and we tend to get different opinions. When they started so-called alternate day regime, I was against it. I wrote it down. I spoke. Who will go to this center to get the alternate medication? A daily wage earner. What will he do that day? He won't get the pay. He won't get the money. He will neither feed himself nor he will feed the family. Are we not doing a disservice to the treatment? Any tuberculosis also needs supportive therapy. In addition to drugs, you have to give him nutrition. So if the man is going to spend time in to and fro to get a medicine in I would say even a government free center, the whole day is wasted. Now probably I think more or less they give medicines for a few weeks or few months to minimize these chances. There are so many technical difficulties when we treat these patients. There are difficulties. Ideally, we should give everyday drug.
So as they say, hospitals are the ivory towers of society, far away from the realities of day-to-day living. Sir, what is your experience about osteoarticular tuberculosis and its effects in pregnancy, childbearing and the course of pregnancy? Is there any aggravation or increase in the activity of disease in pregnancy?
Well, like diabetes, a person who is diabetic can get tuberculosis more easily. I think when a person becomes pregnant, I think again the nutritional status has got a very big role to play. If the nutrition is poor, some of these patients would get tuberculosis. Nice to talk to such ladies. If it is the first baby, it's the most precious baby. She's lucky that she has been able to conceive it. And many of such ladies may not be able to conceive in future. So first baby, first conception should be respected, permitted progress, however, under the supervision of a qualified obstetrician or gynecologist. I don't think it is a wise advice to get first pregnancy aborted because the mother may not be able to become pregnant again. Tuberculosis does affect the tubes, and many of these people can become or may not be able to conceive. I have never advised people to go in abortion for their first pregnancy and have no regrets. However, you have to tell them that they have to be under close observation by a qualified gynecologist or obstetrician.
Sir, is MDR TB or XDR TB not just drug resistant but also more virulent and aggressive and relentless in its clinical course? Or it is just the drug resistance which is of concern to us?
Broadly speaking, I won't say that they are more aggressive, but if it's a MDR or XMDR, there's probably a suspicion that more than one DM can be appreciated in these people. Generally, we look at one clinically actively and in normal case of tuberculosis, but in people who are MDR or clinically refractory cases, I think many of them would show more than one active, clinically appreciable active LEM. I think that is what gives you some idea. Look here, the immune system is so poor. Patient is in MDR and XMDR. The patient is getting more than one active, clinically visible LEM.
HIV with tuberculosis any special experience or guidelines from using?
One of the most terrible things. But the treatment remains the same. The doctor must be careful himself. Aspiration, ulcer formation, these are very common things in them. The treatment is the same in addition to immunopotentiation and the help of the HIV specialist. But a treating surgeon or a treating physician must be extra careful because you have to aspirate many of them, you have to dress many of their ulcers, so you do take precautions.
Sir, can we request you to please elaborate or enlighten us about immunomodulation a bit?
Whatever is at present clinically available, there are many attempts being done all over the world. They are wanting to do gene manipulations, cytokine manipulations. But when it comes to practical, in particularly clinical practice, up till this time, I don't think any of them has come into clinical practical application. We have been using, we call it immunopotentiation technique. Well, it is in the literature. We give 4 injections. First injection, BCG. After 1 month, second injection, BCG. After 1 month, third injection, DPT, fourth injection again DPT at 1 month interval. What are we presuming? BCG stimulates CD4 stimulation. DPT, generalized stimulation of adaptive immunity. Along with all this, we also give levamisole, which is given at bedtime. Give levamisole for 3 days, 3 nights. Give a gap of 7 days. I repeat, levamisole for 3 days, give a gap for 1 week. The total treatment lasts for about 5 months. After 5 months, we stop it. And during this very time, we could find that CD4 count, the study was done, the chief person who was doing this was Dr. Anil Arora. CD4 count before we started this treatment was about 200, if I'm not wrong. And after this treatment, around 4 months after the treatment or 5 months after treatment, CD4 count was raised to roughly 400. That is a lab confirmation or lab support to say that this immunopotentiation technique was practicable in clinical setup in our country and it could help the patients. We have used this thing for, again I'm using the word, we have used it for clinically refractory cases, particularly who had multiple lesions. We have succeeded in 80% of patients, along with anti-TB drugs, immunopotentiation, anti-TB drug, supportive therapy. We have succeeded in 80% of patients. Roughly 7% patients die within 5 years Once you make a diagnosis of MDR, XMDR, do whatever you like, roughly 7% patient will die. About 8% will persist with grumbling disease. Roughly 20%, 80% or 85% recover.
So what is the cause of a particular typical appearance of matted lymph nodes in tuberculosis?
Well, clinically, a single isolated lymph node can occur due to any disease, an injury, an ulcer, but somehow matted tuberculosis is matted lymphadenopathy is considered suggestive of tuberculosis. I won't say it is typical of tuberculosis, I would say suggestive of tuberculosis. That's it. And if you can palpate the matted lymph nodes, don't hesitate, put in a needle, aspirate. If we are thinking of a doubtful diagnosis of tuberculosis infection in the knee or ankle and there are lymph nodes, obtain the tissue not only from the joint but also from the lymph node. And ad nauseum, repeating, whenever you try to obtain a tissue for diagnosis, subject them to 3, 1, histopathology, 2, microbiology, 3, serological test. Every time, whatever tissue you obtain, try to get all the 3 things done. It may help you in many cases. I won't say it will help you in every case.
So what is the optimum time of total hip replacement in TB hip?
Minimum 1 year of a healed status. I am repeating again, minimum 1 year of healed status, not only in that joint, but any part of the body. The disease should have healed not only in that joint, but also in the lungs, also in the spine, also in the lymph nodes. The patient should have been in a healed status of any infection for at least 1 year. I usually use the word 1-3 years. That's the word I use, 1 to 3 years time. There is an article in the recent Journal of Bone Joint Surgery which I mentioned like this. If a patient had an earlier infection of a joint during a joint replacement surgery and you want to repeat another joint replacement, there are 3 times more chances that the new joint replacement will also get infected. So one should keep it in mind, the source. If there is still a source of culture media lying in the body, even in the lymph nodes, upper part of the lungs, glands of the intestines, wait. Let the disease heal for at least 1 year or ideally 1 to 3 years, then operate.
Sir, why do deformities of tuberculosis of hip vary in various stages of disease?
Stage 1, synovitis. You need more space for the fluid to be accommodated. So the limb lies in some degree of flexion, some degree of abduction, some degree of external rotation. And that is the position in which our capsule can contain maximum amount of fluid. It is a fresh case. Capsule is not contracted. But if it lasts for a long time, the capsule will start contracting, muscles will go into spasm, and in stage 2, you will start getting flexion, adduction, and internal rotation. Because by the time, the reaction will start, fluid, now it starts reacting, the capsule will start getting infected and shrinking, muscles which were in earlier spasm, even they may start having more spasm. The capacity, you need more capacity only during the stage of synovitis or when there is a lot of fluid in the joint. In the rest of the time, the contracture of the capsule and spasm of the muscle will bring it to flexion, adduction, and rotation.
So, are there any indications of arthrodesis of hip in today's practice?
I think in today's practice, arthrodesis of the hip should be an obsolete operation. However, the biological operation of axial arthroplasty is still valid. After failed treatment of infected hip arthroplasties, accepting an axial arthroplasty is a rational option. And if the patient is young, one can modify this axial arthroplasty to provide more stability and more function to a young patient. Now, what are those? I'm sure many of us would know it. In a young person, the axial arthroplasty can be supplemented by give a pelvic support osteotomy. Upper end of the femur can be osteotomized with convexity to the medial side, and you get a upper femoral girder stem as well as pelvic support osteotomy. In further younger people, you can add even a shelf at the top of the greater trochanter by doing what we call tectoplasty, or combination of tectoplasty and innominate osteotomy. All this can be done as biological procedures for a grossly infected hip joint.
So, what are the routes of biopsies in cervical spine? Is it possible to do minimally invasive biopsies?
FNAC can be done in the cervical spine from the front. Let the patient relax. Make the patient comfortable. Patient has to be comfortable. Identify the median structures. Trachea, oropharynx, nasopharynx, esophagus. In reality, just shift the median structures to one side and carotid sheath and mastoid, sternocleidomastoid, to the lateral side. If the patient is relaxed, if the patient is not hyperlordotic, hyperkyphotic, if you have shifted these two structures, median to one side and carotid sheath to the other side, you are right in front of the vertebral bodies. You can put in a needle, aspirate the cold abscess, or reach the vertebral body, do an FNAC. In most of the cases, you will be able to get the required tissue for testing. But the patient must be relaxed. It's a beautiful space for reaching the anterior surface of the vertebral bodies, disc spaces, etc. Beautiful.
So, your insights into management of triple deformity of tuberculosis of knee?
Today's clinicians should not create it. We should diagnose them much earlier. X-rays are available everywhere. Even if MRI is not available, we must make a diagnosis early. Avoid it. Once it is there, in an adult, if the deformity is severe, especially if there is loss of flexion, one may consider these patients for knee joint replacement. Will an upper tibial osteotomy help? I'm not quite sure. After all, what is the deformity? Upper end of the tibia has gone backwards, upper end of the tibia has gone laterally, upper end of the tibia has a lateral external rotation. Will an osteotomy help? I'm not sure.
Thank you, sir. That was almost 40 years of your great experience. We were lucky to have been able to imbibe these great pearls of knowledge from you. Definitely a day to remember for us. Thank you so much, sir.
Thank you very much for examining Tuli Ram on these difficult subjects. He still does not know many things. He's still a student. There's so many patients, I feel lost. And then I talk to Apurv. Apurv, क्या करना है? वो बताता मेरे को.